Good afternoon, good morning. My name is Steve Van Warmer, President and CEO of PH Aware Global Association. We're very excited to have you here again today for our On Air with PH Aware summer series of webinars that explore the remarkable evolution of pulmonary arterial hypertension from its earliest challenges to today's breakthroughs and the promising future in research and patient care. So, whether you're a patient, a caregiver, a healthcare professional, researcher, advocate, these live conversations offer valuable insight into how far the PH community has come and where it is headed to next. And we are really thrilled today to have an amazing doctor here. Dr. Sandeep Sahai is here today to explore the evolution of combination therapy from an era of a single drug treatment to today's personalized strategies that target multiple disease pathways. Dr. Sahai is a pulmonologist and pulmonary hypertension specialist at Houston Methodist in Texas, where he serves as the medical director of the pulmonary hypertension clinic there and is an associate professor of clinical medicine at the Weill Cornell Medicine. His clinical and academic work focuses on pulmonary arterial hypertension as well as other forms of PH, with particular expertise in risk management and individualized treatment strategies. He is actively involved in clinical research and education of pulmonary hypertension and has contributed extensively to the advancing of the understanding and management of PAH, including the use of combination therapies and the evolving treatment approaches. So following his presentation, we have some time for your questions. So please kind of throughout this lecture, if something comes up, you feel free to put it on the bottom of your screen. There's a Q&A tab. You can also simply just put it into the chat, and Dr. Sahai will answer that at the end of his lecture. And finally, I want to give a big thank you to our webinar sponsors today, Merck and Liquidia. Through the strategic use of innovative technology and compelling storytelling, we here at PH Aware help amplify the voices and experiences of patients worldwide and foster a more informed and connected worldwide community. So your support, again, is greatly appreciated. So without further ado, I want to welcome you all to Combination Therapy, Redefining PAH Treatment Strategies. Dr. Sahai, thanks for being with us today.
Great. Thanks, Steve. Thank you so much for having me and to discuss this interesting topic. And thanks for people joining in to listen to me. I see Hunter is there. He's probably the one who orchestrated the Ambition trial, so he could probably fish in more in-depth information. So sorry, Hunter, I'm calling on you for this. But anyway, we'll talk a little bit about scientific rationale on why we use combination therapies, some of the data. I'm not going to go into too much of data, but we will discuss some of the rationale that how this field evolved. And let me share my screen. Okay.
Looks good. We see it.
Okay. Let me. I'm gonna swap screens. So is it still good or no? No, it's not good. Now you're seeing it. Hang on.
Yeah, we're seeing the secondary one.
Okay. Is this good?
Yep, great. Thank you, sir.
Okay. So the whole idea about the combination therapy started probably, I would say, in late 2000s. And as you may know, as therapies, I think you saw in this, you probably attended the previous lecture by Dr. McLaughlin when the first therapy came, and then she talked about the prostacyclin and the history of PH treatment. And then, of course, over a period of time, there are more and more therapies evolved. And the big question, which we are actually even today sort of still learning and struggling, I would say, is how we can best optimize our current therapies. And these are just the main points which I would be touching on in today's therapy talk. So I think many of you already know that historically we had three major pathways: endothelin, nitric oxide, and prostacyclin pathway. Over a period of time, these drugs were discovered from late 90s. prostacyclin was the first one, then bosentan, ERAs, then nitric oxide, and all these, and subsequently different formulations of these drugs targeting these pathways were developed over a period of time. Definitely, we have dented the mortality in PH to some extent, but it's still not there where we want. The median survival, as you know, this is the historical data, is around 2.8 years without treatment in PH, which is still pretty bad. And before we had these, what we call as PAH targeted therapies, we actually didn't have anything for these patients. And we used to use anticoagulation because we used to think that there are like small thrombosis in the pulmonary vasculature. We used to use calcium channel blockers. In certain patients, we still use it, oxygen or lung transplantation. And think about late 80s when even the lung transplantation was not there. So people used to basically have nothing for them to help with this fatal disease. Then, of course, the prostacyclin came, which I think Dr. McLaughlin discussed in detail in the last webinar, so I'm not going to go into detail. And then subsequently, all other pathways slowly were discovered and coming out with different therapies. And some of the landmark trials, we know that I'm just kind of listing Seraphin, Griffin, and PACES. PACES was sildenafil, basically PDE5 inhibitor. Seraphin with macitentan, which is currently used. And before that, the emrisentan also was discovered, and that's being used. And then selexipag came out around 2015, and then we used. So the big question came that when we had all these, so we started from the era in late 90s to with one continuous infusion. Now you have 3 or 4 um, therapies, oral pills, which you can use. Initially, our initial thought was like it's a natural understanding that you give one drug and then you treat patients with that drug, and then if they don't do well or they start to get worse because it's a progressive disease by nature, then you add the second drug. And that's what we mean by sequential. And then in 2015, 2013, this the MB around that time period, the ambition trial was started and it was published, which kind of changed the whole paradigm of how we think about the disease. So what we used to do is that we start patients on one drug therapy, continue that. If they do worse, then you add the second drug, and then they do worse, then you add the third drug or something like that. That's kind of like in a sequential manner. But this trial, which, as I mentioned, Hunter is here in the audience, and he can correct me if I'm not saying anything right. He's the you can see his name there in the paper. He's one of the ones who led this trial. Was about the combination treatment. What if we have a newly diagnosed patients and we start them on 2-drug therapy from the very beginning? And I highlighted some of the statements from the introduction of this trial that, and I'm going to just read them and try to explain you the rationale behind those. No single class of drug is consistently effective in treating all patients, which suggests that no single pathway plays a dominant pathogenic role. So our understanding, I mean, still we do not have that kind of a precision medicine where we know that one particular drug would be better for a patient versus other. Uh, I would say vasoreactivity testing, which we do, that is sort of a type of precision medicine because we can identify these vasoreactive patients, and we know that calcium channel blockers would work really well on those patients. And if they remain vasoreactive, they may just stay on calcium channel blocker for the rest of their lives and pretty much have a normal life expectancy. However, the majority of patients are not vasoreactive. And if they're not vasoreacting, we still do not know which pathway is triggering the pathology in a patient more than the other. So it makes sense to use combination treatment. Then we started using combination therapy, which can target the disease from multiple pathways. We clearly identified the 3 major pathways back then, and this trial was one of the big one, which sort of lamented this combination therapy in PAH. And I'm just going to briefly touch the study design. That treatment naive and newly diagnosed patients with PAH, it was randomized initial ambrisentan and tadalafil combination they used. So the study design was, it was a randomized blinded controlled trial where patients used a combination of ambrisentan and tadalafil versus a monotherapy, which was the conventional way of treating, means you use either tadalafil or ambrisentan. And the primary endpoint was, it was an event-driven trial. So the first event of clinical failure, a composite of death, hospitalization for worsening PH or disease progression or unsatisfactory clinical response. So with that, the trial was done, and it actually showed that the arm where the patients were randomized to the combination had a 50% less of these endpoints, means the disease worsening, mortality, morbidity, all that. So that kind of changed the whole management paradigm in PAH, that we should be treating patients with the combination treatment. And that's, if you look at even the most recent guidelines, even the most recent recommendations from any of the guidelines, it still holds true that we have to treat patients with the two-drug therapy to begin with. And then we introduced the concept of the risk status, and I will briefly touch on that. But this is where the rationale of combination treatment came, and the guidelines adopted it, and you will see repeatedly in different versions of guidelines this has been recommended. It is now pretty much the standard of care that all these patients should be started on this particular combination. However, now we learned something from this trial. We have started I would say, the evolution of treatment in PAH, that we started believing that combination therapy works. And if two drugs worked, why not target all three drugs together? Like, why do we have to wait? And if you look at the current guidelines, they talk about that using that, you could use all three pathways in a very high-risk patient. So patients who are diagnosed newly, some patients, you do the risk stratification. If the patients are low and intermediate risk, you can still use two-drug pathway as per what the ambition two-drug combination as per what the ambition trial showed us. But if you have a patient in a high risk, means either they're in RV failure or they're decompensated or pretty bad hemodynamics, we recommended that, or we recommend, the guidelines currently recommend that we use three drugs pathway to begin with, including the parenteral prostacyclin. So this is a natural thinking. And if I'm just going to take an example from the cancer world, and if you know some of the diseases like lymphomas and all, where people at the time of diagnosis, they get like these 4 or 5 intense phase chemotherapy or whatever. Like, I'm just going to take an example like R-CHOP for some sort of lymphomas. I'm not expert in oncology, but you get rituximab, you get cyclophosphamide, you get steroids, you get other drugs also in the beginning. So after that 4, 5, 6 cycle, then you start weaning them off. So we kind of started thinking in that direction, that should we be using in PH also, because the mortality was still very high. So then this whole combination, the thought of upfront triple therapy came. Like, we were successful with 2. Are we going to be successful if we start using the 3? So then this was a big study. Big in the way it was a good proof of concept study, but the sample size was 20 patients, not in terms of the sample size. From Dr. Sidbon in France, his study basically showed that if you use parenteral prostacyclin, bosentan, and sildenafil, I think they had 20 patients or so, they actually showed at 5 years almost close to like 100% and 90+% of survival, like pretty good survival. So that also supported this concept that we could use triple therapy. And that was sort of the basis of using the Triton trial, which used, and I will talk about Triton. So learning from these things, we thought that if dual worked, And that study showed benefit of using all triple pathway. The Triton study was designed, which was again newly diagnosed PH patient, initial combination of macitentan, tadalafil, and selexipag. Now keep it in mind that in this one it was not the parenteral prostacyclin. The selexipag was used, and then the control arm was just the two-drug therapy. So now we are testing patients with upfront triple versus upfront dual combination. The primary endpoint was change in PVR at week 26. And PVR, as many of you may know, it's a hemodynamic parameter. And at week 26, to see if that will show benefit. So these were the results. What happened was actually this trial did not meet the primary endpoint. It actually, in simple words, you can say it failed. What it showed that dual and triple combination both showed pretty similar improvement in the PVR. So two-drug therapy was sort of equally effective as the triple therapy. And now, as you may know, the guidelines do not actually recommend triple therapy as the starting regimen for PH patients, except they are on in heart failure or very bad concerning hemodynamics, which is defined as PVR more than 12 Wood unit or cardiac index below 2. Then you may consider using the triple therapy, but that the third agent will be a parenteral prostacyclin, not oral selexipag. So the lesson we learned from this trial that not all the combinations are same. So when we talk about different combination of treatment, a combination of two oral therapy like tadalafil, macitentan, and selexipag, a combination of tadalafil, macitentan, and parenteral prostacyclin, they're not the same. They're different. Or the combination of dual oral therapy with the parenteral prostacyclin may be able to achieve better hemodynamic or long-term better outcomes. There were a lot of discussion about Triton study, like what happened, like why this study did not meet. Some people felt there is a nice editorial, and you could by Jane Leopold in Jack, and you can take a look, and it talks about maybe the 26 weeks was a short period. Maybe we would have done endpoint driven, like the disease worsening endpoint instead of hemodynamic study to assess maybe in long term. It appeared that the patients who were on selexipag, they appear to have some benefit in long term, but of course the study was not designed for that. So, but it also told us that the dual therapy is also pretty good therapy. If you start people on at least two-drug therapy from the get-go, you do get a pretty good response in patients. And then you could add additional therapy if needed, depending on how bad their hemodynamics is. So then this was another interesting paper came out from the French registry. Our French colleagues and friends published this very interesting study. They looked at initial monotherapy, initial dual therapy, and initial triple therapy, including the parenteral prostacyclin. And what it basically what we learned that all initial triple therapies are not the same. Parenteral prostacyclin is not as same as selexipag, so there is a difference efficacy. A parenteral prostacyclin adds potency that an oral prostacyclin receptor agonist may not match in severe disease. What their study showed that the younger women who had very severe hemodynamics to begin with, and when they were started on the parenteral prostacyclin along with the background oral combination, they actually had way better survival in long term. And the highest risk patient gains the most from early aggressive prostacyclin-based therapy. And this statement, I think, is very important to understand as a clinician, as a patient, and I think everyone who is involved in PAH, that when you are seeing a patient who has a very severely high hemodynamics, it's very important that we treat them aggressively with the prostacyclin-based therapy. And this is what our older data is, and I'm not talking about in 2026, because now we have sotatercept also, and I'm going to bring it up in discussion, but I'm just trying to show you some historical data that how the evolution of combination therapy started. Upfront dual therapy is a standard. High-risk patient may need more therapy. So it's not just the triple therapy. We can use quad therapies also now, but the guidelines currently support at background. But if you look at the trials with sotatercept, all of these patients were already on their maximum tolerated combination therapy. Either if you look at Zenith trial, they were stable on dual or triple therapy. If you look at the high risk, not Zenith, the Stellar trial, Zenith was a high risk patients who were on the maximal tolerated therapy, and they were at a very high risk of mortality. They were still in high risk, and then you added sotatercept in them. And so now there is even more reason to use combination therapy, because you have a fourth agent which actually shows remarkable benefit and improvement on the background of 2 or 3 drug. And if you look at the beauty of sotatercept data is that if you look at across the board, all sort of like they did, Hyperion trial was in the newly diagnosed patient. Zenith was in high-risk advanced disease who were already maximally treated. Stellar was in the stable patients. And if you look at the results of all these trials, there is definite benefit of adding the drug in regardless of what combination treatment they were on and regardless what stage of the disease they were. So clearly, there is benefit of adding therapy if the patient is not meeting the treatment goal, which is, at least as of today's, the guidelines recommend using the low risk as the treatment goal. So this is a nutshell overview about the combination therapies, that how the evolution of combination therapy happened and where we are today. I talked about main studies. I did not go into more data on the sotatercept, but I just wanted to leave the more time for discussion, so that I'm sure in the audience we'll have a lot of questions. It's a newer therapy, and of course it is tested on the patients who were on combination treatment. Okay, these were the references, and Steve, I'll be with you. I think I need to stop sharing my slides. Okay.
Thank you so much. Great. Thank you so much, Doctor. So yeah, to the people participants here, again, you can put any questions you have here in the Q&A tab at the bottom of your screen, or simply in the chat function, and we'll get to those. So please take a moment to do so. But I'll ask you a couple questions. Sandeep, just some kind of baseline stuff for patients that might be joining here, right? Tell us a little bit about more in depth about what risk stratification really is and what all that means and how that plays into all this stuff.
So risk stratification is basically um, an objective way of assessing what patient's risk of mortality is. Because as you know, this is a fatal disease. And of course, once unfortunately you get diagnosed, you carry the risk of death. And the risk stratification tools are more prognostic to tell you what those are. Now, having said that, there are multiple tools out there. So sometimes I know from patients' perspective, they might get confused, like, okay, well, I read something online, they talked about Compara, then someone mentioned about Reveal, or some guideline mentioned something different. So let me just try to simplify it for patients so that they understand what these mean. So as you may know, in the different parts of the world at different time periods, there were multiple registries conducted. In the US, we had a Reveal registry early on, I would say mid to late 2000. We had Reveal registry. Around the same time, and it's ongoing in Europe, there is a Compare registry, then there is French registry. So all these registries, what they did, and we knew certain things from the very beginning when we started knowing about this disease, that NT-proBNP level is prognostic. It tells us, like multiple studies and data has shown, it tells us the stress on our heart or the right side of the heart. And if it is high, it's not good. We knew that the walk distance, and many of the patients, when they know that they go to their doctor's office, they're asked to do the walk distance. And the functional class assessment that doctors, when they see you, they talk to you about what all you are able to do, how much you are able to do, how much you can walk, what things you can do. That helps them assess your functional capacity. So these were the three main things. Now, and this data was collected in all of these registries. So what they did, our colleagues and investigators, that they looked at the prognostic value of these parameters and some more parameters also, like Reveal actually looked at 13 different parameters, some imaging, some pericardial effusion on the echo, which is a poor prognostic sign, or hemodynamic parameters also. So Reveal came up with their own scoring method that if you meet these criteria, that means you are either good or bad. Same way, Compera came up with their own scoring score method. With now, how does it work is in clinical practice. Like for example, if someone is I would just give an example that generally all of these scores have 440 meters as the cutoff for the walk distance. So if you're walking more than 440 meters, you are basically low risk. Or if you're looking at the NT-proBNP level, if it is below 300, it's considered low risk. And then there is a range between 300 to 1100 for Reveal, and then there is a range for Compera also, and Compera splits into, I think, intermediate low and intermediate high risk, and so there are different cutoffs there which are learned from the studies. What it basically tells you, and I will just say a very simple rule of thumb, is that if you are low risk, you carry less than 5% risk of mortality in a year. If you are intermediate risk, the risk is somewhere between, you could say 5 to 15 or 10, again, depending on different registry, different types of data. And if you are high risk, you are carrying 15% or even more than 20% risk of mortality at 1 year. And there are different iterations of different risk scores. Like recently, there is a recent paper which I got the honor of authoring with Dr. Benza. He modified that Reveal score, and if the Reveal score is below 4, it's kind of like a filtering out ultra low risk patients, and it can also predict of the morbidity and mortality. This just came out a few months ago. So these are the risk scoring methods, and you could, those doctors who know, and if you go to your doctor, you could definitely ask them about what your risk score is. And then therapies, treatment decisions are based on that. So if you are low risk, we say that, well, whatever therapy got you there, just stay on that, you are doing fine. If you are intermediate risk, means you may need more tweaking. We may have to do something, add more therapy or do something more. If you're high risk, then you definitely need to do more. And let's say you are high risk and you are on maximal therapy, let's say 3 pathway, and then maybe the 4th pathway now, sotatercept, and you're still at high risk, maybe it's time for transplant or something like that. That's what, how you utilize risk score in the clinical practice.
And I think this is there's a question here from Hunter, which I think kind of drifts off that too. Great, he says, great presentation, by the way. He said you once talked about potential withdrawal of therapies believed not to be working, or substituting substitutions like Real Sequat or PDE5. How has the community thinking about this currently?
Yeah, he's asking me tough questions. No, no, I think field is really thinking about it. I'll tell you about the withdrawal therapy, and again, for those who are not familiar about the withdrawal trials um, and why this question is there, and what Hunter is trying to ask is, so as you may know, PH is a fatal disease, and nowadays we have so many therapies that I should not say so many, but we have more therapies compared to early 2000s, that that we could use multiple combination. We can try to apply different approaches. We have learned so much that even we now better utilizing therapies also, whether it's in combination, even the doses, and also we could use all that data to improve someone's outcome. However, back then in early 2000, we were, let's say, in the era of sequential therapy where we were using one drug or two drug and waiting if disease progresses, then you add the third drug. At that time, I think there were certain trials done, and I can't remember the names right now, but there were certain trials done where therapies were withdrawn to switch to some different drugs, and sudden decompensation happened in patients, and we sort of got afraid or worried that taking therapy off from patients may lead to decompensation. But so since then, as a community, as the researchers and trialists, we stayed sort of away from um, uh, trying withdrawal trials or withdrawal therapy. However, this question becomes very relevant now because now we have better drugs. We know how better to use them. And patients generally, many of the patients, if you look at the trial data, they are very stable. If you look at the walk distance is pretty close to 400 meters. They are doing um, way better now compared to what they were in early 2000s. So the question comes, if we have to understand what is the impact a therapy is doing, could we conduct withdrawal studies? Specifically, this is more relevant when we talk about disease modification. Many people say that some of the therapies like sotatercept and all have those role or capacity to be disease modifying. And if that is the case, then probably we will need a withdrawal study at some point in time to really prove that point. And there are a lot of nuances to that, like if you withdraw the therapy, what should you be monitoring, how long you should be monitored, how long the patient needs to be staying stable to really define as those kind of things. Some of the contemporary trials are actually now sort of extrapolating these angles. So to answer Hunter's question, some of the trials are actually looking into this, they're kind of withdrawing some of the therapies. We could discuss offline. Yes, now what's the other
Oh,
question?
another question that says, what treatment options are available for PVOD, pulmonary veno occlusion disease, particularly in a patient who has shown a complete response to triple combination therapy, bosentan, sildenafil, Ventavis, iloprost, along with other supportive medications?
So, okay, I'm a little confused with this question. If you're saying that the patient already responded to these therapies and patient has PVOD, then why do you're saying has shown a complete response to triple therapy, then why do we want to change anything if it is already a complete response? However, I'm just gonna give some comment in principle. Uh, Most of the therapies, again, I always feel that sotatercept role is so much evolving in the field that we're learning every day something new about the drug. But in our sort of principal mechanistic view, our traditional therapies, we believe that they do have a lot of other disease modification roles too, but their predominant efficacy is more because of the vasodilatation, and that's why we stayed away these traditional therapies in using in PVOD patient. Sotatercept does not appear to work that way. So sotatercept could be a good therapy for PVOD, and that role is still being explored. I think there are some investigator-initiated study. We do not have a lot of data on this as of now, but that could be one option. But however, the way the question is phrased, it appears that this patient did tolerate um, um, this triple combination and is doing fine. And I'm assuming when you are saying PVOD, either this is mutation positive PVOD or you have a pathological biopsy to support that this patient has PVOD. So, but if patient is responding to these therapies and is doing well, I would probably just leave things alone. I would not touch those. I still did not get the second part of the Hunter's question about substitution like Riociguat and PDE5. Once we talked about potential withdrawal, believing not to be working. I don't think I'm understanding the Riociguat and PDE5 question very well, but I'll talk to Hunter anyway. Uh,
Well, let's talk a little bit about your patient and doctor relationship. So let's assume you have a patient who's doing great on combo therapy. Maybe they have two pathways covered. Like, what is um, kind of the determining factor? Is it the risk stratification you talked about? What if a patient says, "Oh, I want to have a better quality of life going on here." Oh, this other patient I heard tried this. Like, when do you? How does those conversations go? Whether
so
it be, hey, getting involved in a trial, or let's try a third pathway, or whatnot.
I personally feel, and I mean, this is something, and again, I may say something which is not written in the guidelines, but the clinical practice, I always say this, that the evidence can help us know and learn, but the clinical decision making in clinic with patient is way more complex, which can be explained in any guidelines. I mean, we know our principles, like we can learn principles from the guidelines, but the application of those principles in the clinical practice is very complex. It's not that simple. There are a lot of factors you have to consider in between. I mean, there is a whole discussion. You may have heard different talks about comorbidities. There is a whole discussion about lung phenotype coming into picture. There is a whole phenotype question about this HFpEF phenotype, which may look like precapillary pulmonary hypertension. So you have to take into consideration all that and make your selection. So my clinical practice, or any doctor's clinical practice who has understanding of the pH therapies and the pH phenotype, can vary or may vary from the clinical trials, because there may be a patient who looks like lung phenotype. I may use a different combination. Instead of using emricetin and tadalafil, I may use maybe tadalafil or inhaled treprostinil, or I may use a tadalafil or sotatercept, which is a totally different combination. But again, these are very individualized decision. Um, when you talk about the risk stratification, let's assume we have a very pure idiopathic or hereditary PAH type of patient with no comorbidities. In such a patient, I would like to know, let's say we do a risk stratification, and if whatever risk, and again, just to, if you believe in reveal risk, you use reveal. If you believe in compara, you use compara. You reveal, you want to use French risk scoring method, you use that, or Swedish, or which one, wherever you are practicing and whatever you believe in. Pick one risk stratification model, longitudinally follow your patient. Your patient is coming for first or second follow-up. You already started them on dual therapy or triple therapy, and they are at low risk. At that time, as per the guidelines, we generally don't do much. We just leave the patients alone. If your patients are and then of course regular follow-up, leave them on that therapy. But if your patient is in intermediate risk, or if you look at the Reveal 2.0 score between 7 or 8, then you would like to add further therapy. And that's where the question is, whether you want to use sotatercept, whether you want to use inhaled treprostinil, oral treprostinil, PGI2 receptor agonist, or switch them to uh, soluble guanylyl cyclase stimulator from PDE5 if you are intermediate low risk. If you're intermediate high or a score of 8, I would probably just treat you as a high risk patient. I would probably just do uh, um, maybe sotatercept or parenteral prostacyclin and have those discussions. So the bottom line is that if you're not low risk, you need to optimize treatment. Now, coming to the low risk, which is one of our Blue Journal paper, we put a little arrow there. If your right heart imaging is not normal or near normal, even if you are low risk, which actually we see in our clinical practice, the younger people, they can walk 500 meters, their NT-proBNP, their RVs are muscularized, their NT-proBNPs are normal, their function class 2, but their echoes look bad, like their RVs are bad. We do encourage an advanced treatment in those patients. So we would like to do something. Maybe nowadays sotatercept appears to be a very good option, which of course shows uh, uh, very good reverse remodeling of RV, that it shrinks the size of the right ventricle. So perhaps that could be an option for your patient. So again, that's something, is an evolving field. We still lack evidence in that area, particularly those who are low risk, and if we need to add more therapy. But at the same time, if you look at the recent paper, Relenipeg, it had like 53, 54% patients on in low risk, and adding the drug showed benefit. Now, of course, we'll need more discussions over it, but clearly it appears that even the low risk patient might benefit adding more therapy, more combination treatment.
How about when you have, or how do you personalize a combination therapy for patients when you might have two patients in your clinic, doctor, that have similar hemodynamics, but they can have different symptoms or different functional capacity or different treatment responses. So, just kind of beyond the guidelines, how do you
Yeah,
navigate?
yeah. So I'm going to give you three different examples in that, okay? Or maybe four. Four is first, which I talked about, a young patient who has no comorbidities and pretty active. Let's say RV looks a little bit bad, intermediate risk, newly diagnosed. We start combination treatment, pretty straightforward. That's like your textbook guideline patient, and then you see the response, how they respond at their first follow-up, and then if they're intermediate risk, then you add. Now, but the real world is not like that, and as you know, that epidemiologically, that the PH age of diagnosis is also getting older. If you look at the Hyperion trial data, the newly diagnosed patient median age was 55, and they had a lot of comorbidities. So now comorbidity is generally sort of divided into either cardiac or pulmonary. Uh, uh, Now, if you have a cardiac comorbidities, of course, you have to do a full evaluation, figure it out whether it's a pre-capillary disease in the patient, because HFpEF PH can also mimic like a pre-capillary disease. So if you feel like that your patient is doing need some pH therapy despite of us, then of course, depending on what the wedge pressure is, if it is a combined pre and post capillary, right now there have not been any trial which have been successful in these patients. We are seeing some positive news with the cadence trial in this combined pre and post capillary patient with the cardiac comorbidities. So maybe this will become a therapy in future. It is going into phase 3 now, so we will learn more about this drug. But you could use anecdotally, again, this is not written in guidelines. I'm just sharing purely my personal experience, what I would do. I give them a trial of PDE5 inhibitor to begin with, and then depending on what the response is, then I could probably add more therapies. If you're looking more of a lung phenotype patient where you're looking at older patient, maybe some lung parenchymal disease, I generally use PD5 or inhaled treprostinil in these patients. Tend to avoid ERAs in older patients with comorbidities just because it can cause fluid retention. So just tend to avoid. But nowadays, sotatercept is a very good option because it doesn't have those kind of side effects. So that's how kind of I decide into these 2, 3 different type of patients. Does it?
There was a follow up on that
Uh-huh.
PBOD question, Cindy, and she was saying that can a number of medications be increased? For example, moving from triple to quadruple therapy. Part one question, and then at what is your opinion on lung transplant as a treatment option, or I'll just ask you of just getting a lung evaluation at what point in a patient's treatment regimen?
Yes, so yes, the short answer is that's what I was saying. So if you look at all the sotatercept trials, they are pretty much done on, I mean, if you look at Stellar had like 60-70% on the background on triple and 4 drug was added. Even Zenith trial had pretty similar number. I can't remember exact percentage, but significant amount of patients were on 3 drugs and then fourth was added. So the short answer is yes, you can receive 4 drug therapy and actually moving on. Most of the trials we are going to see data. Many patients will be on quadruple therapy. So that answer is easy. And the second, what is your opinion on lung transplantation as a treatment option? Um, it is the ultimate treatment option. I mean, if you are not responding to any of the therapies and you are still symptomatic or functional, or your disease is progressing despite of trying all the therapies in maximum capacity, then yes, transplant is the option. And I would suggest earlier the better. Get evaluation done, make sure that uh, I always tell patients that when we talk about transplant, it's not something that you just go there and you get the lung transplant. And it's a complex process. You have to um, first, you have to be assessed by the transplant team to know what is your candidate suitability is. And during the process, you also learn about your transplant team, that these are the people you will be undergoing a major surgery, and these are the people you will have to see these doctors forever for the rest of your life. And you feel comfortable with them, you can trust them and all. So it's in my mind, it's always a two-way process. So and I know we always think wherever we live, and that's the only, like, whatever is your nearest transplant center, and that is the only option. But my personal opinion is, I tell my patients to go and seek whatever number of opinions you want, because it's about your life. I mean, you don't feel satisfied, you don't need to feel obligated that this is the only place or this is the only doctor I need to be. I mean, you could go wherever you want to, as long as your insurance is covering your trips and all that, because that's the very important part of the transplant. So yes, that is an option if you are mentally ready. And some people ask me all the time, what is the right time of the transplant? And I find this question very difficult to answer. I always tell patients that this is my philosophy, that the right time for transplant is the day you feel that you cannot live your life the way it is. That's your time for transplant. I mean, you've done everything, you explored everything, all treatment options, and you feel like you just cannot deal with this anymore this way. I guess that's the day for you to go for transplant.
That leads to this question, I think, is you're talking a lot about getting to low risk or lowest risk possible, but really, just from your seat, what does treatment success mean to you or the patients you serve, just beyond risk calculating scores and numbers like
Yeah.
that?
For me, the success of the treatment in PH is if I see, of course, normalization of right ventricle, because or normalization of hemodynamics. That's what I feel is the very effective treatment. And to be honest, I have probably seen that more in last 2 3 years with the advent of sotatercept versus years prior to that, because the drug actually. So my philosophy is simple. You define pulmonary hypertension with hemodynamics that your mean pulmonary artery pressure is high. If I'm saying the effective treatment, then your mean pulmonary artery pressure should also come down to normal. It's like your high blood pressure. Like if you have hypertension and you check the blood pressure is 180 by 100, then you take bunch of blood pressure medications, and the goal of the treatment is to bring your the systemic blood pressure down. The same is for high cholesterol treatment also, that has to come down. So I believe that your combination treatment should be in such a way that that in the maximum capacity, your pulmonary artery pressure needs to come down, your right ventricle function should get normalized. Those should be the ideal treatment goal in my mind. And till the time I'm not able to achieve that, I try to optimize treatment. That's how I go. That's kind of little deviation from what the guidelines really say. And the guidelines are not able to say that. I mean, I think everyone in the room agrees with what I'm saying, but we just cannot, because we just don't have the evidence to show that this is. But we believe, and we are working on generating that evidence.
Let's take a moment here, like just everything you're talking about and presenting here today and have been involved with across your career in this combination, in these multiple pathways, really is a function, obviously, of clinical trials. And maybe you could just speak a little bit about the importance of clinical trials in your clinic, just in your perspective, and how that has gotten us where we are today, and kind of embarking on where we're poking at here in the future.
Yeah, my pretty standard treatment in my clinic is I always tell my patients, like whoever walks into my door, you will be asked about some study at some point in time in some shape or something. I always believe that all patients are a potential for some sort of clinical trials, and that's why I very actively screen them, which may be a candidate for which trial. Um, I think clinical trials is a perfect opportunity for PH patients to explore for multiple reasons. One, this is the only way for patients to get access to medications which are not easily or readily available for commercial use. For example, I'm going to give example of sotatercept. That I think the first trial, the phase two, was started like in back in 2016, 17, something like that. And we had many patients in that trial, the Pulsar study. And those patients were started on the drug back then, and the drug got approval in 2024. So I think our patients were at least on the drug at least 6 or 7 years before it got commercialized. So what I'm trying to say, if you introduce such a therapy early, you might be able to see a good response in your patient. Sometimes, in unfortunate situations, um, you might be on the other side of the spectrum where, let's say, your disease is fairly advanced, your RV is failing, you're on a lot of oxygen, and for some reason, let's say you're not a transplant candidate for whatever reason. And in that case, an effective drug in the trial might give you an opportunity to improve your situation at that time. Having said that, since it is a trial scenario, and I'm not trying to discourage, but I have to be honest and realistic with patients that there is always a chance that the drug might not be effective also. I mean, we do a bunch of trials, and many of us know that in the last few years there have been many trials which have failed also. So if there are trials which have failed, then I mean, of course, that's no one can predict, but that can happen. And if that happens, then I would say go on to the next opportunity. Maybe talk to your investigator and consider another. I think this is one area where we need more therapies. We need effective therapies. We need better delivery of therapies also. We need less side effects from therapies. Yes, we have made success, but I still believe that we have room to go um, up and more in this field. So without patient partnership in the trial, it's not going to be easy.
Just a couple more questions for you,
Yeah.
Doctor. Here's a couple forward. We're looking at here into the future here now. So, do you think, looking ahead, do you envision PAH treatment evolving from combination therapy towards simultaneous targeting of even more biological mechanisms, or maybe is the next advance going to be identifying which patients don't need certain pathways at all?
Yes. That's a fantastic question, and I think we are kind of entering that era now. It does appear to your first part of your question that with sotatercept, we are able to, I mean, there are some publications also, and in our clinical practice, we are able to wean off certain therapies from certain patients, like those who responded very beautifully to that. As I mentioned, there are some of the trials currently being done, which are actually trying to answer the question which Hunter was trying to ask about the withdrawal therapies, whether we can withdraw certain therapies. There is some data which is going to be presented in some of the conferences in near future, which actually talks about some phenotyping and some unique genotype of the patients which respond uniquely to certain drugs and which could be very useful in clinical medicine, then you perform like like in cancers, like they check on the estrogen receptor for breast cancer, and then that this patient would respond with these therapies better because they are this receptor positive. I think we need that kind of precision medicine, and I think we are reaching, at least in certain areas, it appears that our investigators, colleagues, and collaborators in translational and basic science are working on it, and it appears that will be the future in next 10 years or so.
And how about, I'll leave you with this one. If you can kind of go backwards to those very early days of combo therapy, that era, and give any clinicians that are joining us here, one lesson of how we could have treated or should treat PAH differently than we did 20 years ago, what would that be?
Yeah, there are a lot of things which comes to mind on that side, but I think this is, there is a saying that you should not beat yourself up for your past, because because I think that was the best we could do at that time, right? That's what we had at that time, and or understanding. I mean, it's just a natural evolution that how we have evolved in combination treatment, newer drug discoveries. I mean, certain drugs. Imagine if sotatercept was discovered back in late 90s, then what? Then what would have we have done with other drugs or oral pills or something? I don't know. I mean, these are difficult questions to answer. I think one thing we could do more, or should have done more. I think ambition was a fantastic timing. To do the trial. Perhaps sort of like an I don't know. I'm just kind of making it up. Like maybe an upfront triple, like which was like Olivia Sidbon study, something like with parenteral prostacyclin. Maybe now it's time to do one with sotatercept. I don't know in upfront whether we could find out that there are patients you just do and they normalize their RVs. That could be the one opportunity. In the combination therapies. I don't know. I mean, I think that's what I would think of. Um, I feel like the advancement in PAH treatment um, is is um, is twofold. One is optimizing our existing therapies because we still like actually I forgot to mention artisan study which I don't know when that will be published, but which is actually trying to say if you rapidly up titrate the parenteral prostacyclin, you can normalize RV. So that's one part means that you could optimize your existing therapies better. And I think we will learn something from that. And then second is novel therapies, which is drugs like sotatercept, how early, how soon we can use them and normalize the RV function. The other part is the treatment goal, which we kind of touched, but we didn't went into detail. Uh, is low risk status is the sufficient goal? And I personally, I think particularly after sotatercept came for clinical use or became available, I started realizing that maybe we need to aim higher. I think low risk is just not sufficient. We need to look at normalization of RV or normalization of hemodynamics, where our concept of remission comes into play. Again, we need more evidence to that to validate those endpoints. We just don't have enough information, but I think field is moving forward towards that.
Wonderful. Well, I can't thank you enough for a great presentation, answering all these questions. Thank you, everyone participating for those questions. I did want to do just a moment of housekeeping here, if you don't mind. I want to share my screen just as a reminder. I think that's you see that, right, Sandeep?
Yeah.
Okay, cool. Later this week, this is Wednesday, this is 2 days from now, we have another webinar, The Future of PAH, Emerging Targets and Therapies with Dr. Stephen Chan. Later this month, Dr. Benicio de Jesus Perez, on Global Centers of Excellence, Collaborations in Care. And then finally, the last one we have set up at this time is Clinical Trials Matter, the Backbone of Innovation with Gene Elwing. That's on September 15th. You can go to phaware.global/webinars to register for that. And one other thing I'll say to anybody participating here is in a day or two, a playback of this will be on our Heartworks app, which is available now in every app store and Google Play Store on the planet. So you can listen to the playback there. Also, I want to point out we do have all our PH Aware podcasts there. Dr. Sandeep is a frequent guest on the show, and you can find many episodes that he has done there as well. So I thank you again. Let me just back roll out of this so I can stop sharing. So I thank you again, Sandeep. I appreciate it, and hopefully we'll do this again sometime.
Well, thank you, Steven. Thank you for asking me, and thank you everyone for joining. You are fantastic, and it's always a pleasure working with you. Thank you.
Awesome. Thank you, everybody. We'll see you next time.